So this is actually my second career of sorts. I noticed in the program I'm called a patient advocate. And I'd just like to correct that because I'm really a family partner. Though I have to confess, after hearing Daryl Steinberg speak today and previously, it's an intriguing role. And obviously we need more advocates in the mental health arena, so who knows? Maybe that'll be career 3. So anyway, good afternoon. I am Bonnie Hotz. I'm the SacEDAPT family partner, but I'm also the parent of a child with a pretty severe psychotic mood disorder, my daughter Rachel, who was treated at the EASA clinic during the period of 2008 to 2010. And having now been on both sides of the treatment process as a parent and now as a family partner, I can tell you with confidence that family partners can be an important addition to your treatment teams. So first and foremost, family partners can fast track building the rapport and trust that's essential to engagement in treatment. And that's no small thing, because you can get people in the door, but keeping them there and keeping them engaged in treatment is really what makes the difference. I really can't tell you the number of times I've seen barriers come down in the clinic as soon as I mentioned that I'm a parent of a child with a psychotic mood disorder. I've seen all kinds of reactions. People literally jumped out of their chairs. Faces will light up, tears fall, stories come pouring out. I've had people simply grab my hand and hold on. That's the power of lived experience in treatment. Families bringing their children into treatment often have a diverse mix of emotions, from confusion, fear, shame, anger. And I get that because I've been there. And when families feel safe sharing those feelings, when they feel understood by the treatment team, they're more likely to participate. And when families participate, their children have a higher probability of getting better faster. So families, of course, are more than their sick child. And understanding their big picture can go a long way towards breaking down barriers to treatment. And the family partner can help speed up this process by getting to know the client's family and using this information to help the treatment team tailor their approach. So in the SacEDAPT clinic, I do this by meeting with each family soon after they come through our doors and letting them tell me who they are. And I'll give you some examples. So a father might share with me that extended family has not been told about their child's illness and how that has strained their family ties. A grandparent might tell me that in their culture, hearing voices and seeing spirits is considered a gift, and they're not convinced that their grandchild is ill. A mother might describe to me how her family is struggling to put food on the table, or has received an eviction notice, or is having trouble paying their bills. Imagine trying to engage in treatment for your child's illness when you haven't told other people. Some family members don't agree that that child is even sick, or when your basic needs like food and shelter are at risk. Having a family partner on the team who can address these and other issues helps clients and their families be more available to treatment. And this is where the family partner's role in connecting clients and families to auxiliary support services comes into play. And this is probably the more traditional role that you think of when you think of a family partner, is in connecting families to services. And it's a very important role. And you can see by the slide, there are a number of things that a family partner can help with in a family's lives to make them more present during treatment, because maybe we can relieve some of the worries that they have. Lastly, I wanted to talk a little bit about how family partners engage with the clinical team. Because unfortunately, I think sometimes family partners are more like an administrative type position and they're off to the side. And that's not the case in the SacEDAPT clinic. Integrating family partners into the treatment team itself, I think, is really where you're going to maximize their value. So what does that mean? Well, it means that partners actively participate in team meetings where clients are discussed by doctors and clinicians. And why is that? Well, we can add context because we've gotten to know a family. We can share a recent interaction with a family member that is important to the discussion. Or we can be asked to address a need that a doctor or a clinician has learned about in their session. So we're a resource to them. Having family partners as part of the team also means collaborating one-on-one with clinicians to address treatment challenges. And let me give you an example. Not long ago, one of our clinicians suggested that I join her at a home visit with one of our families. And at that home visit, I shared my lived experience about the challenges I had when I had to make the decision whether to include medication in my daughter's treatment. And this family was having a similar hard decision with their young son. Shortly after that visit, that family did allow medication, and that young client has improved to the point where he can actively engage in therapy, so all that's good. But my point is that working together, the family partners and the clinicians, we each bring our strengths to bear, the clinician's skill and training, my lived experience, to help the family have their voice and be an active part in the decision-making process when it involves treatment. And that's really important to families, I think, is to feel like they're a part of the process and not just being told what to do. But the main value, I think, of integrating partners into the treatment team is to represent the client and family perspective whenever there's an opportunity. And it's a two-way street. And this is a small example, but I wanted to share it with you because I think it brings out an important point. Late one afternoon after a long day, one of our clinicians came to speak with me about one of her clients. And the clinician was understandably really frustrated with a parent who was not providing consistent medication oversight. I mean, that's a basic thing, right? Well, having struggled with my own daughter's resistance to medication, and at times failing to be her consistent monitor in that regard, I just said, I get that. I totally understand that. And the clinician was, whoa, what do you mean? You work here. What do you mean you get? Well, you know, and I told her the reason is because sometimes it just gets to be too much. It's too much. You're working, you have other children, you've got other stresses. You know, at the time my daughter became ill, I was also caring for elderly parents in my home. It was very tough, and sometimes it's like, I can't go there tonight. So hearing that from me, someone the clinician knew and respected as a part of the team, really made a difference for her, I think. It made her step back and just reminded her that, you know, these even simple things that we think should be easy for families to do sometimes are challenging. So what did we do about that? She and I then talked about how we could help that parent find a less impactful way of taking that needed break, and to also introduce the concept of self-care for the caregivers, which is a really important thing for our families. So I've heard it said that families are the secret weapon in the battle against mental illness, and I truly believe that. My daughter, Rachel, after so many really terrible years of struggle with her mental health, recently said to me, she said, "Mom, I don't know where I'd be without you and Dad." And by bringing lived experience, I think, into the treatment process, I know we can help more families be there for their kids. Thank you.
So today, my presentation is influenced by the questions that so many of you submitted to the survey that we sent out. And many program administrators, counties, clinicians wanted to know, what would you do differently? What did you learn? How do we implement these programs on the ground? And so that was what I structured my talk around, was lessons that I've learned in doing this in 3 counties, here in Sacramento with Cam Carter, and then in Napa County with Aldea Child and Family Services, and then in Solano County with Solano County and Aldea. So I'm going to talk about those things. So these are some things, and I collaborated with Rachel Lowy, who's also led the prep clinics, because we were like, what are the things we want people to know? So this is what we put together. First and foremost, and this came up today, Rachel alluded to this before, hire people who want to work in this population. This is not typical community mental health. This isn't child mental health. This isn't adult mental health. This is transition age youth mental health. This is very different. So you want people who are committed to that population and committed to serving youth and families who are really struggling with serious mental illness. So one of the things we tend to find is that there are clinicians in particular that come with chronic serious mental illness experience and are like, oh yeah, I've worked in a board and care or a group home or a hospital. Yes, I want to work in this population, and that's great. However, there's also some challenges that come with that are good to know about. Those folks have worked with really ill individuals, and so they come in with this view that all of these kids are going to be very ill, and many of them aren't. Many of them are still in school, still with their families, still have friends. And so the clinicians then hold this stigma about where these kids can go. They're like, well, if we can just keep you off the street, that's great. No. The goal is, how do we get you to college? That's the goal for these kids. So making sure that folks really know what they're getting into, that they're open and willing to work in the population. Dr. Heinsohn talked about the coordinated specialty care model for the goal of what you're trying to build when you're trying to build a program. And one of the challenges I think we have here in California is we have rural counties, we have urban counties, we have rural urban counties, kind of like Sacramento. And so each county is unique and their availability of resources is unique. But for this sort of work, you have to look towards that model. And within that model, there are key components that you need to have. And we'll get questions about, well, is it okay if we just have a doctor and a clinician? And the answer is really no, because Bonnie's just given you an example of what she brings to the team. And that's very important. Supported education employment is very important. A good doctor is important. Having the team meeting is important. All of the coordinated specialty care model pieces are important. So how you choose to actualize that is up to you, but those are important pieces. And you need to have enough effort across those different people to actually function as a team. If you have, 0.5 of a physician, that's probably not enough for this population. So these are the different things to think about. Develop partnerships with other agencies within your area and your county. Sacramento County, they're over here, I'm pointing at them, has been a fantastic partner with us in building our program. At the very beginning, we sat down with them, and they were willing to talk with us about how we pay for it, how we document it, the assessments, and how we do them. And we were really creative. And our program wouldn't exist the way it does if they hadn't been willing to work with us. So we are deeply grateful to them for their support. And coming to Solano County, because they're over here, they did the same thing. Well, some of them are over here, and are continuing to do it. And that partnership between the clinic and the county is sometimes doesn't seem like what happens. And I think Sherry Steiglin alluded to that before. There's some places where these clinics exist where there isn't that clinic-county partnership. And so much more can be done if you guys work together. Create a community advisory board. Dr. Carter did that before I came up here from UCLA, and as a result, we have all of these rich partnerships with different areas of our community, the schools, different school districts, the county, different organizations within the county, and that enriches us and allows us to support them. A comprehensive and consistent outreach plan is critical. You need to target the points of first contact in your communities for individuals where they're seeking mental health care. Is that the ER? Is that some sort of crisis service? And then spread out from there. A broad community outreach campaign isn't as effective as going to your ER and targeting that. So you'll want to kind of build a plan and then use your community advisory board to inform that. And then you're going to want to be patient. It's going to take some time before you build enough referrals to have a full program. And Sacramento County knows this. They watched us patiently and supported us, and they're still doing that. Solano County is doing the same thing for the SOAR program there. It takes some time, especially when the program's new. So I'm saying this out loud so all the counties hear it. You have to be patient. Be ready for referral sources to be frustrated with you and confused by your limitations. As Rachel was alluding to before, typical county mental health plans are set up where somebody calls an access point, access then farms people out into adult or child, and they just take whoever they get, and this program is not that. There's age restrictions, there's duration of illness restrictions, maybe there's substance use restrictions, and that's really different. And so it takes a while to train everybody in the county as to what that is, to have them get mad at you when you don't take the clients they want you to take, to then educate them about why based on the model. And over time, they'll get used to it. But in the beginning, they're gonna be really frustrated with you. Be creative and willing to work out of the box about everything. Again, this isn't a typical program. As every meeting I have with Sacramento County, they're like, well, you're unique. And I'm like, yes. And we are. And so you've got to then be willing to be creative and flexible in order to accommodate that uniqueness, whether it be in the funding streams you use, the documentation that you do. And the amazing piece about MHSA funds is they're very flexible. Some of the pieces of our model are covered by Medi-Cal. Great, bill Medi-Cal. That's fabulous. But some things aren't. We do phone screens for an hour before we ever see someone face to face. You've got to have that as part of the model because you've got to be able to screen people out who aren't eligible, but Medi-Cal doesn't pay for that, and that's where MHSA funds can be used. So think about how you can leverage these different funding streams to build the program that you need. Be broad, but not too broad in who you choose to serve. And this is a really important piece. Do you have the clinical staff capacity to serve the population you're proposing to serve? So this is one of the challenges we had in Napa. We had a very small community. We were trying to serve as many people as possible. And so what we did is we went down to age 8. And as a result, we've had some challenges. Are these 8-year-olds, psychotic or not? We don't know. And then the treatments, we're like, we're not sure if the meds are appropriate for this. And so now we were sitting there being like, well, we tried something new and maybe it wasn't right. So, it's good to think about what you have the capacity to serve. Do you have a doctor who feels comfortable serving 8-year-old psychotic children? If you do, that's amazing. Please introduce me to them. I'd love to meet them. It's a rare occurrence. So be thoughtful about that when you build your criteria. And then be willing to change if what you decided to do didn't work. Again, as Toby was speaking about before, innovation. We're trying new things here. We're kind of pushing the boundaries, and that's amazing. But be willing to take a step back and reflect if it's not working. This is a collaborative care model, and it's recovery-oriented. And I think this also touches on some of the points that Bonnie was making. Oftentimes I get phone calls, or when I'm out talking in the community, I'll get questions about medication non-adherence, or what do you do when they just don't want help? They want help. They really do, just not for the things you think they need help for. You're like, but they need to not hear voices. And that's not what they care about. They want a job or a car or a girlfriend. Great. Let's capitalize upon those goals as a way to motivate them towards wellness and recovery. So I think these are really important things, is to understand where the client is coming from, to motivate them towards wellness. See family members, however you want to define them, as an asset and not a burden. Bonnie really spoke to this. They are often still involved when we get these individuals, and we need them. Dr. Carter often says that the family is the frontal lobe. These are the people that are keeping an eye on what's happening in this person's life and helping to guide them. They are important. Get information from them. Give information to them. Use them as part of this team that you're building. It's not just the clinical team. The family is part of the team. So it's very important not to exclude them. And we sometimes hear, well, there's confidentiality issues. Well, get an ROI, you know? And when the individual walks in, just say, we are a family-focused clinic. We will work with your family, but we need your permission to do that. And let us tell you why that's important. And sometimes you might have to work with somebody a little bit to get those ROIs, but just get an ROI. And use that family. And this is where it gets really challenging when you have folks who've worked in the adult system. Because in the adult system, and we know this because our clients come from the adult system, and their family members are told to stay in the waiting room, or like, I'm not even sure why you're here right now. I'm gonna meet with your 19-year-old son. And then they come to our program and we're like, come on back, both of you. And the family members are often like, wait, what? You wanna hear what I have to say? Well, yeah, we do, you're very important. And that's a very important piece of the model, but also of providing good care. For clinicians, you know, sometimes it's really hard to let go of people. And so one of the things that I think is very important about this model is to remember you're working towards recovery and reconnecting individuals to their natural support system. You are not trying to provide lifelong care. So you need to say, come in, let's help you, and then goodbye. And that's what this should be about. So you are going to reach capacity in your program. You're going to need to graduate people, and they are going to go into the world of less optimal care. So when they leave, and you've been meeting with them every day, and they're going out into an adult system of care where maybe they're going to see someone once a week, and if they're lucky, there's a group, that is a shock. So in our programs, we need to support them intensely when they need our support, and then titrate things down, see if they're okay. If they're not, then scale back up, and then again, and try. It's like, you know, a kid with training wheels and a bike, right? You don't just stick your kid who's been using training wheels for years and then take them off and throw them out into the street. You'd expect them to fall over, and that's what will happen here too if we don't plan for that and use our program to build towards that. So, okay. It is essential to collect outcome data. We have heard this all day today. And that is really because it is our responsibility, for those of us who are these providers, to show that these things are effective for everyone in California. So we really need to measure things not in a typical productivity fashion, not in a head count fashion, but in a meaningful, are they getting better, do they have jobs fashion. And, you know, it's been pointed out to us that those of us who have established programs need to be leaders, for those of you who want to build them. But we need help in how to do that. There's not enough of us to support everybody. So how is a state or are the counties going to come together to build the capacity for training and consultation?
I would start off by saying, do everything Tara and Rachel said to do, and you guys will be fine. And their wisdom is really, I think what this day has really been about in a really critical way. My name's Steve Adelsheim, and I am thankful to have a chance to speak with you all for a couple of minutes this afternoon. I would still say I'm a newcomer to California. I've been here about 2 years. I spent 28 years in New Mexico, where I worked there for quite a few years, initially doing work in school mental health. And one of the things that I sort of want to just, I feel like part of my obligation as a child psychiatrist that actually would see an 8-year-old with psychosis, is to say that don't forget, and you hear this all the time, half of all mental illnesses have their onset by the age of 14. And that as we are looking at building out these models, it is very important that we really think about, you know, maybe not necessarily focusing on that 8-year-old who is very rare, but really looking at, you know, our adolescents, our middle and our high school students, and really looking at the entire continuum of support that might include school-based programs, that might include early intervention, that might include, as was suggested, people who have dropped out of school, and really that continuum of support. And when you look at countries that have done a really nice job of dropping the duration of untreated psychosis, it's getting down to 16 years old. And it's not everybody necessarily who's 18 or older, or 19, or out in a potential community college or college setting. And so I just think as programs are being developed, linking to schools is a critical piece. The outreach to schools is important to keep in mind. So, I hate to extend and focus on the broader piece, but I really think we have a public mental health crisis in this country. And I think that we have a lot of work to do in building early models for young people. I think this is a critical one, but as was referred to earlier, if we can build components that will identify young people even earlier and link them to services, that's a really critical role to do. So because I really came from the child adolescent world, I was really sort of late to get involved in this world around early psychosis and prodrome related work, and had the chance to get involved in clinical research for the first time a number of years ago before I left New Mexico. So I had a chance to be part of the EDIP study with Cam and with Tara and with Ryan, and then later the RAISE study, and we were one of the RAISE sites that Bob talked about, and had a chance to learn a great deal about specialty care models and all of that as well, in what was a pretty rural and remote state. As I moved here, people have been incredibly gracious and welcoming, and I've moved to Stanford, which really hasn't had a program in this area. And so we've been having a lot of catching up to do, and have wonderful colleagues who are sharing a great deal with us and helping us move forward. So I feel very lucky to be involved in this work at this point in time. I was asked to share a little bit actually about some of the models in New Mexico for support, because I think, as Tara was mentioning, I came from a state that certainly was small population-wise. I live now in Santa Clara County that has a larger population than the state of New Mexico. And we had very rural and remote communities, and basically didn't have a Mental Health Services Act. And we were very poor, which leaves that state having to be creative in a whole other set of ways. And, there are a couple things just model-wise as we're thinking about support and infrastructure, I think it's important to think about. I ran a Center for Rural and Community Behavioral Health, and our focus was on supporting community partners. Many were tribal. It was important to look at culturally based models of care for different communities. It was important to develop questions and solutions with communities. And we had to deal a lot with distance. And one of the things that's been striking for me coming to California with the county-based model is somewhat of a disparity of resource between larger and smaller counties, and the inability of every county to have the same potential access to the same types of services. So, one of the things that I've talked to some people about here is sort of regional structures and ways that smaller counties can come together, which was certainly something we learned to do in New Mexico. We did a great deal of support via televideo. A lot of the modeling we did, a lot of finding child psychiatrists was done through televideo partnerships, with really the goal of increasing the capacity of the other providers to be able to provide support. So a lot of our work was really consultation with teams like you on a regular basis, where there would be a training talk as well as then case presentation with multiple sites simultaneously, to be able to share from each other's cases as they were presented and experience. And then everyone's capacity improved in terms of learning how to manage difficult and complicated situations. And by doing that in a multidisciplinary way with a variety of the team members that one would see in specialty care, everybody is able to learn their role and learn how to partner in a better way. And maybe if you don't have a component of service, there's someone else maybe in a neighboring county that can help you develop it or be a partner in terms of that service. So I think it's a model we need to think about here in New Mexico, here, see, there I go, in California, as we're talking about sort of building the coordinated model here in this state. And so, one thing in relation to that was just striking to me was that as I moved to Santa Clara County and was learning about the different programs that were here, I had a chance to learn about the program in the county I was in that really focused on supporting people with prodromal or ultra high risk issues. And in the county a mile away from me, there was a great program, targeting people that had a first episode of psychosis. But if you lived in the wrong county, you didn't get the program maybe that was the right program for you. And so, one of the things that I think I was trying to understand early was, well, where are these programs and how are they connected? So we started talking to people at all the different programs and ended up basically putting together a simple listserv to start connecting the people that were involved in the programs in the different counties around the state. And that sort of has been a nice task, but we haven't sort of moved forward with that in a big way yet. On a similar time, though, we started having conversations on the federal level. And Dr. Heinsohn and the people at SAMHSA and the folks from Robert Wood Johnson Foundation that had helped us do the EASA study supported a number of us in coming together at SAMHSA. It's probably a year ago this week, I'm thinking, and Cam was there and Rachel was there and Bob and a number of folks to start looking at this issue of developing a national network of all the different programs that are involved in this early psychosis work, with really the intent to start building some connection and collaboration. And out of that discussion came this program that you have a copy of this piece of paper in your folders today, PEPNet, which certainly is not yet EpiNet, but I think has been, as we think about it, our first step in linking together the different programs around the country that are involved in early psychosis work. We started out really trying to coordinate the different training programs that were happening around the country and help them come together, figure out who was training who, what the training needs were around the country. We now have a treatment group that is starting to have dialogue around what are the core treatment components that we need to develop to ensure that fidelity is happening as programs are coming up quickly. And as you remember from Bob, they're growing very fast around the country, and people are concerned, we all are, around the fidelity and ensuring that people are getting good training and consistent practice as they're started. And now we're actually starting a work group really asking people with lived experience and family members to be at the table to help sort of guide all of our processes as well, and are excited that that group is going too. So while we're waiting for EpiNet to really sort of get moving, and while we're talking about the California coordination piece, I would ask all of you to sort of sign on and join us as we really are trying to start linking programs nationally, but also I think within California. And as we pull together the people from each state, our hope would be that all of you involved and us being able to even know who's out there in each county doing what will allow us to sort of have the core body to start building this broader coalition here in this state, and then support the coalitions in other states as well. So, I'm hoping that I can continue to partner with all of you, with these wonderful research institutions, of which Stanford is one, but not so much yet in this area, to help support these efforts going forward. So thank you.
Good afternoon, everyone. My name is Dina Tyler, and I work for PrEP Alameda County. And today I'm going to talk with you about peer support in an early psychosis program. I've worked at PrEP Alameda County for over 5 years, so I've been there since the beginning of the program, so I've gotten to see the whole evolution of this program. And peer support works really well within the PrEP model, as they share the philosophies of being recovery-based, strengths-based, and person-centered. Incorporating both clinical and peer support approaches at PrEP Alameda have increased engagement because clinical and peer staff can come from different angles to find the best ways to support the mental diversity of the young adults that we serve. And I quickly want to cover what is peer support. A peer can refer to many different things. It can refer to someone that's close in age to a young adult. But in the context of mental health services, it refers to someone with personal lived experience of the mental health system. It is an emerging term that more people prefer over consumer. However, there are multiple ways in which it's used, so it often needs some clarification. There are people with lived experience, either personal or as a family member, who are then hired to work in clinical roles, so as a therapist or a case manager. Sometimes the word peer can also refer to a family member that has helped a loved one navigate the mental health system and then works with other family members, like Bonnie. And But what I'm going to focus here today is those with their own personal lived experience of the mental health issues who work as peer specialists and provide peer support. So the definition of a peer supporter is someone who has firsthand knowledge of the healing process of a mental health struggle and building resiliency. They can offer genuine compassion and hope that it is possible to come through those struggles stronger, with more clarity and purpose. Peer support is an evidence-based practice. It is a system of mutual support and learning founded on the key principles of hope, equality, respect, personal responsibility, and self-determination. Peer specialists practice trauma-responsive care by being trained to hold people in unconditional high regard and remain non-judgmental in their interactions. A peer support relationship is about openly listening to what a person has to say, and then responding by strategically sharing parts of their own personal story. Peers avoid pushing any kind of personal agenda and can share mutuality without the constraints of the traditional expert-patient relationship. The relationship is key in peer support. Coming from the perspective that each person is an expert on themselves, the role of a peer supporter is to empower the individual to find out what works best for them to take care of themselves. Peers can also serve as advocates to help transform services to include more wellness, recovery, and resiliency-based care. Peers can improve outcomes through effective engagement to reduce involuntary care and inspiring others to take personal responsibility over their own wellness. And I'll share with you a little bit about my story before going into my work at Prep Alameda County. I was given my first diagnosis of attention deficit disorder in high school at the age of 18. I was given 3 more diagnoses by the age of 22: severe depression, bipolar, and psychosis NOS. When my provider started mentioning schizophrenia as a possibility, I stopped talking about hearing voices. I was terrified to get that diagnosis. I was prescribed many different medications, was hospitalized, put on disability, and ultimately came off of all my medications, all before the age of 24. Back then, there was not a program designed to specifically meet my needs and understand what I was going through. I had to learn how to navigate the mental health system by just going through it. And it took a while to figure out what I needed to do to ultimately exit the mental health system. It took about 7 years from my hospitalization to go back to school to complete my undergraduate degree. I was one of those that had to drop out of college. After graduating from UC Berkeley with highest honors for sociology with a focus on mental health, I found an ad on Craigslist that for a young adult outreach specialist. The ad said, "Person with lived experience of the mental health system preferred." And that moment was life-changing for me because it was the first time that I saw that all of that lived experience, all that I had been through, could be a job qualification. And it was an amazing feeling to think that I could help others by using all that I had learned from going through the mental health challenges and navigating the system. This would have been so incredibly helpful to me if I had somebody that I could have talked to a lot earlier in my life that had recovered. In my 5 years at Prep Alameda County, I've held 3 different positions. As a young adult outreach specialist, I thought I would be meeting with young adults and talking to them about coming into the program. However, my main responsibilities were to develop the outreach materials and give presentations to providers about how to make a referral into the program. And then as someone with lived experience of being diagnosed with psychosis as a transition age youth, I really wanted to use my lived experience to be helpful to the providers, to the young adults, and how to engage the young adults. So I began to advocate to help with program development for peer support services that would foster hope, empowerment, and recovery. Some of the initial challenges that I faced were with personally disclosing amongst a primarily clinical staff. I had faced a lot of stigma in my life and from family and friends, and it was really hard to think about putting out there something so personal that could result in distancing from my coworkers. And so I had to work really hard to show the value of my personal experience and that clinical staff could come to me if they were struggling to engage a young adult, and I could share with them what it's like to be on the other side, and what worked to reach me when I really seemed unreachable. After 2 years, I was promoted to outreach coordinator, and a large part of my job was to share the peer recovery perspective in all the different meetings, including the operations and executive level meetings for the program. And now I'm the coordinator of peer and family support services, in which I supervise the family support specialist and any peer supporters involved in the program. We've hired many people, in different positions with lived experience. And then we also bring in interns from a local peer support training in Alameda County. We have a family support specialist that does a lot of the duties, the groups and MFG, individual peer support and family support, similar to like Bonnie does. And then in my position, I provide individual peer support. I also facilitate a wellness support group, that's a peer-run support group, hearing voices groups. I've brought in other facilitators with their own personal lived experience to run RAP groups, the Wellness Recovery Action Plan, and special messages groups. All of these are peer-run groups, and they're still available to all PrEP participants once they've graduated the PrEP program. They can still come back to go to those groups. I've also created a graduate program to help mentor young adults that have completed the PrEP program that are interested in working in mental health. So I create individualized opportunities for them based on their own interests. So some of the graduates, I've helped them to become the RAP facilitators or hearing voices facilitators or peer supporters. And for those that are interested in stigma reduction, I've trained graduates that are interested in sharing their story publicly. So I've trained them in a disclosure training called Coming Out Proud program. I've also created a social media internship for a graduate that was really interested in sharing articles and information to dispel the myths around mental health struggles. And so he posts on our Facebook and Twitter. Some graduates have come back to serve as peer mentors in our current participants by being group facilitators, like our RAP facilitator, or sharing their own lived experience, either individually or to the groups. And I also work to build community outside of PrEP through helping to build the Bay Area Hearing Voices Network and connecting PrEP participants with local peer recovery networks like the Pool of Consumer Champions or even other national or international networks of people with lived experience. So really helping them to create a community of others that have been through it so that they know once they leave the PrEP program, they have a whole community out there to access. And I just want to mention that there's a statewide peer support certification in California, so that's hopefully going to lead to a lot more opportunities for peer support in all mental health programs. And one of the challenges and barriers has been, throughout my time at PrEP Alameda, we've really had to work hard to create a supportive environment for incorporating peers into the workplace. I train the clinical staff on how to use non-stigmatizing and recovery-based language, either in the presence of the young adults they work with or amongst other staff, because we do have people with lived experience that are not currently out on staff, and so they sometimes can hear an offensive word or something that sounds stigmatizing. And it's really helpful to create an environment where we're all being mindful of how we talk and the power behind our words. I provide peer support supervision to those with lived experience and help support them with any feelings they have about working in a clinical environment. And along with the clinical program manager, we've worked to address any feelings of division or hierarchy between the clinical and peer staff. And I just want to also mention that there is research currently being conducted through Stanford on the experiences of peer staff in early psychosis programs. This is an international study, so we'll hopefully have a wide range of insights into the best possible ways to incorporate peers and the value that they bring into early intervention. And last slide I'll just end with is this is just a bunch of different peer specialist training programs.
Okay, so the program name in Oregon is EASA. That stands for the Early Assessment and Support Alliance. Probably the most important letter in our acronym, EASA, is A, and that's Alliance, meaning that all programs across the state of Oregon engage in the same practice with the same criteria with kind of the same oversight, and that's part of my job. I oversee all the clinical practices for EASA across the state through Portland State University. We even have agreements amongst all of our counties that have EASA programs that if one person moves from one county to another, you know this is a young mobile population, right? That one program will automatically pick up that other program without a rescreen, rebarrier, anything like that. So some of the agreements that we've come up with as in Oregon. I just want to mention our mission very quickly, which is keeping young people with early signs of psychosis on their normal life path by building community awareness. Obviously, that's our community awareness campaign, obviously an optimal and critical component of early psychosis programs, and then offering easy, accessible, effective treatment and support through a network of educated community members, that's the community education, and highly skilled clinicians using the most current evidence-based practices. I will note that all of our evidence-based practices that we've integrated into EASA have all been modified to kind of fit the culture that is young adults with psychosis. And we've developed those modifications to the evidence-based practices through active feedback from our participants, family members, and clinicians. This is Oregon. It's not as colorful as this map looks. We're all green now since our passage of marijuana. What I just want to kind of point out, which is I also call job security, is 2001 is where we started, was kind of our salmon-colored programs, and that was $600,000 of reinvestment funds from our MHO that covered those 5 counties. They're going to one-time funding. They said, we're tired of people going into the hospital with first break psychosis, going right out of the hospital, then coming right back in. Here's a book from Australia, do something about it. So that was our first introduction to early psychosis. I got onto the team because I knew a little bit about CBT. And they said, I guess there's some CBT involved. So that's ultimately how I've ended up standing and talking to you today. From there, we got our first legislative appropriation in 2008, which kind of expanded to all the blue counties. About 2010 to 2014, these 3 yellow counties jumped on board, and they did this without any funding. They just liked the work that we did. They knew that more funding may be coming around, and they wanted to get on board. So they just used their straight Medicaid dollars, and they continued to see people without Medicaid. So that was just kind of part of their own sustainability plan, which they kind of took our advice, which is your best sustainability plan in these programs is that every day someone's going to develop schizophrenia. That isn't going away. So you might as well do something about it now. So they jumped on board. And then ultimately in 2014, they came on board with kind of these green counties, and then ultimately all the starred counties is kind of all of Eastern Oregon. And these counties over here, some people mentioned, I was also asked to talk about kind of rural sites, like Malheur County. I think there's like 7 people in Malheur County, and we're still doing some early psychosis work. This is what our team looks like. I use the term transdisciplinary team because we have shared responsibility. It's a little more advanced language than, say, a multidisciplinary or interdisciplinary teams. And I use that language because of some of our rural communities that, obviously in our larger communities, we can have a program director, a team leader, some kind of prescriber, a nurse, a social worker, a counselor, supported employment, peer support we're integrating in, occupational therapists. Other counties, we don't have that luxury, but we still want the coordinated care services, as kind of Tara mentioned how essential they are, but we may not have individual people doing each one. So we might have a social worker and a counselor with a shared role, or even a counselor and a supported ed with a shared role, just to kind of make sure that those specialty care needs were met. The problem with trying to do too much of this in rural counties, then you get like some supported ed person with a 0.001 FTE that really then ultimately has no time to do early psychosis work. So I'm very much an advocate in rural counties to consolidate the jobs and follow this more transdisciplinary model. We call these, I got a couple of data points up here, not so much just to show outcomes, but to show the type of outcomes which have resulted in our ongoing funding. These are some of what we refer to as our moneymaker slides. These are non-scientific. These are not randomized controlled trials. These are just simply our program outcome data, which we share with legislatures. They're not, we don't do a lot of symptom measures. That hasn't really got us that far with our legislators. But these have. It's kind of our school and work outcomes. People are very much interested in that. This is our hospitalization slide. I guarantee your data will look exactly the same once you starting an early psychosis program. High levels of hospitalizations early, dropping down to almost nothing over the course of a 2-year program. Another moneymaker slide. So these are the type of data that you should be presenting to your legislators and to your funders. And then, of course, pair these slides with personal stories. I remember one legislative session where we showed these data, and we were very proud of it, no funding. Went back for the next session, showed these data, had several family members and participants tell successes in their program. And I watched one of a senator, which I know was absolutely opposed to our work, or at least funding our work, a tear went down her cheek. That might have been like a dollar sign just falling from her eye, because I knew at that point we were going to be funded, and we certainly were. So it's not necessarily about your hardcore randomized controlled data. This kind of stuff with some personal stories will work. So how else did we do it? We've established, as I mentioned, this common statewide practice that's articulated through a set of our own practice guidelines. We've written our own practice guidelines. Those are available on our website if you want to look at those. They kind of mirror what Australia and other early psychosis programs have done kind of across the world. We also integrated practices specific to Oregon in our practice guidelines. We've built on existing evidence-based practices. People are obviously very interested in those, so we're simply articulating, we're just doing evidence-based practices with a very specific population. Our counties have seen this as an opportunity really to meet the state's mandates of integrating evidence-based practices. So they bring an early psychosis program and we'll do these evidence-based practices 2 in 1. Obviously engaging key champions, community mental health directors. They were all involved in writing our practice guidelines. We have monthly strategy group meetings, which all community mental health directors are encouraged to attend. They don't always attend, but encouraged to attend. Vocational rehabilitation is a big partner of ours. They've funded many of our grants. In fact, they've just given us money to do the work that we do. Communicating efforts with legislators to the Olmstead Act, state hospital reforms, kind of these big Supreme Court decisions also can ring bell with legislators. And then I'll mention this, including program graduates and participating in educating funders. As I said, that's what really kind of pushed our programs forward, is when we started including those powerful stories from family members and participants in addition to our data. And then creating targeted, simple written communications, which does include data and why the program matters. We have like a 1-page legislative sheet that we hand out, which has data and personal stories on it. Follow us. We also have a major social media campaign. Here's our website, our Facebook page, Twitter handle, hashtag EASA Community Oregon, please, and our Tumblr account as well. So a wide range of kind of social media efforts as well. I'm not one that says, hey, I'm talking, put your cell phones down. I say, I'm talking, put your cell phones up, and if you have a QR scanner, you can scan that right now and go directly to our website and kind of see the work that we're doing. Thank you very much.
Let me tell you that early psychosis is not my area. So I want to just put it on the table. But I had been very much involved with dissemination of efforts and especially to diverse communities of the work that out of the Center for Reducing Health Disparities and also the Clinical and Translational Science Center. I'm the Director of Community Engagement, that we have done quite a bit of that. And so it's been fascinating to hear the data, to hear the stories in the course of today. And let me tell you, as a group, you have very cool acronyms. RACE, PrEP, PEPNet, EASA, EpiNet, and EpiCal. How about that? Is catchy, is great for communication. So you have some of the rules of dissemination. But let me ask you, how many of you are related to the counties? I know that many of you. Wow, this is okay. So let me let me tell you that one of the pieces that I have been hearing throughout the day is that we have to do better at telling the story. And I think that for me, the story today has been about the sound basis of the scientific evidence that we had been hearing, across the day. Excellent designs, very promising results. So there are two questions related to that. We have to do better at telling the story. One is, what is the story that we tell? And I think that it was Senator Steinberg who said, you collectively know how to solve the issue of early psychosis in a way that is important to communicate, the story. But the other question is, who is the audience? And clearly, as I have appreciated throughout the day, it is primarily counties, but also community partners. And so I think that those are two very important pieces of information. So one of the questions is how to tell the story to this primary audience in a way that increases, from 17 counties to many more counties, 58 counties here in California and in other states as well. So there are a few things that I would like to share with you, knowing about the time. One is when we talk about dissemination strategies, there are a couple of things that I would like to share with you. One is that there are many definitions of dissemination. Actually, I had been reading this book on dissemination and implementation research in health. And Bob, NIMH has played a key role in the development of this book and has funded a lot of that research. So one definition of dissemination is the targeted distribution of information and intervention materials to a specific public health or clinical practice audience. And clearly you are a clinical practice audience. So one of the questions is how do we, or the group here, communicates with you in a way that is compelling, with very good stories to tell in a way that there is a greater uptake. Well, let me tell you that one way to disseminate this information is not necessarily, although that is important, on something that Toby mentioned, the publishing thing, which is what we academicians do. And it's important, I don't want to undermine that. But one of the pieces that is in this book is, and I'm gonna quote, numerous studies have shown that dissemination of evidence-based interventions using passive methods, publications in professional journals or mass mailings, has been ineffective, resulting in only small changes in the uptake of a new practice. So if it is not through the publications, then how this is going to be accomplished? I think that this meeting today is a great opportunity to share information in which there is exchange of ideas, exchange of information, there is networking. But there is another audience that I think that is of critical importance that I not necessarily see here today, and that is how you, health providers or policymakers, administrators, communicate with the populations that you serve, especially here in California. And we are the most diverse state in the nation. So there are tremendous challenges on how to get across, in a very simple terms, and in a way that is compelling, so families and individuals get involved. I was one of the themes that also came across, at least to me, throughout the day, it was the issue of engagement, to do meaningful engagement. Engagement with families, as Bonnie presented to us, engagement certainly with individuals, and engagement with communities as well. Bonnie, you mentioned something that really stayed with me, and that is when families participate, they have a better probability of getting better faster. And then I think that it was Dr. Stephen Martyr who mentioned that if you take a look at what are the early signs of who will do well in treatment, it is the patient's experience with the medication a few days after starting the treatment. There is no question that engagement is of critical importance, and I don't think that we academicians types don't do much. I mean, sufficiently, at least, sufficiently with the people who are going to be the ultimate beneficiaries of whatever we are doing. So, if it is engagement and if it is dissemination, at the administrators and health providers, how do you go about doing that? Well, there are many pointers on how we engage whatever public we are targeting in a meaningful manner. And I clearly, in the program, Ken Wells and Loretta Jones are going to be speaking about community engagement specifically. So I'll leave it to them. But there are some factors that I would like to emphasize in terms of the meaningful engagement that are important to consider. There is serious work that had identified factors influencing dissemination, and such as the information that you are providing, to what extent is credible information that has a sound scientific basis on what you are trying to disseminate, including knowledge of causality. And I think that you have. The other piece is the source. How do you do it? By which means do you do that? Which I think that this particular forum is a great example. But there are things like clarity of the content, like perceived validity, perceived relevance, cost of the interventions, strength of the message. But there is one piece or two pieces that I would like to emphasize to finish my remarks. One is from the perspective of those who will benefit from what is to be disseminated, is our perceived values, preferences, and beliefs. So that goes to the families and to the individuals that are the ultimate targets of this, but also the health providers and the administrators. So there are things like, what is the role of the decision maker here? The personal experience or involvement, willingness to adopt innovations, willingness to accept uncertainty, willingness to accept risk. All of these are very important factors that all of us have to consider as we get into the bus of increasing those who are going to uptake this sound scientific information to continue to do so much good. The final factor that I want to mention is the context. We need to consider what is the context of the people that the messages are being disseminated to. And one of them is the one that I will finish with. Among others, there is politics, timing, media attention, financial or political constraints, and you did a wonderful job, Toby, highlighting some of those. But one of them is culture. Culture. How we really disseminate this wonderful information to very diverse audiences in which sometimes they don't even have words for mental health, you know, even less for something as detailed as early psychosis. So if you allow me, this is based on the experience that we have had trying to disseminate complicated, you know, knowledge that we are in the business of generating to diverse audiences. And these are kind of general pointers, like use ethnic-specific media, that is very important. Give educational talks to groups at churches, temples, community agencies, and schools. Use radio ads. You know, there are some populations that's the main source of information that they rely on. Post flyers on community bulletin boards. Use health clinics, recreation centers, family service agencies. Use libraries. Promote through in populations that I work with very often, like which are English as a second language schools, for example, promote that through those kind of schools. And also collaborate with ethnic churches, and then finally partner with social services agencies serving the community. So there are many pointers that you can look at, but you have those two layers of two audiences that are so critically important in order for this to uptake. Thank you.